instabilities is still a major problem after total joint total hip arthroplasty. Fortunately, majority of these are single dislocations that are treated by conservative methods, and the factors that lead to instability is either patient-related, surgery-related, or implant-related. Early instability is either because of component malpositioning, abductor insufficiency, or patient noncompliance. Late dislocations used to be polyethylene wear, but I have deliberately highlighted the importance of unrecognized component malpositioning, which then becomes important with the deterioration in the neurological status of the patient. Options available are these that have been discussed, but I will tell you that the best and most effective is the repositioning of a malpositioned component. And again, sometimes malpositioning of the component is subtle, and unless you look for it, you won't see it. So this one is easy. You can see vertical cup, antiverted, and that can be easily addressed. This, of course, explains why this patient is having recurrent instability. But this particular one is not so easy. Everything at first glance looks normal, but only with this suspicion of a subtle component malpositioning and obtaining cross-sectional studies are you able to see the retroversion of that acetabular component that is the cause of recurrent instability. So when you're looking at somebody with instability, look at the femur and the acetabulum, look at their positioning. One thing, persistent limb length discrepancy is a concerning sign because that usually means the surgeon struggled during the operation to try to stabilize. That's what really led to the limb length discrepancy. This is a classical sign. The plus head with the collar, you can see that was as a result of intraoperative instability. On the femoral side, offset and position. Offset, not all hips are created equal. There are some that are varus, some are valgus, and then you need to use the appropriate components to restore the angle of the hip and also to restore the offset. So some varus necks, some valgus necks. And this is, for example, offset can sometimes be difficult. For example, on this particular patient, it's difficult to know what the offset is, but you have to address that by restoring the soft tissue tension for the hip. Position of the femoral component, you have to compare it with in the preoperatively. Where was the center of femoral head in relation to the tip of greater trochanter? Was it at the level of, above, and if so, how much? So you can restore that by preoperative templating. Remember, there is a version to the femoral stem also, and if you have the version on the femoral stem wrong, and you have the version on the acetabular stem wrong, the component wrong, then that combined version can be a problem. On the acetabular side, you look to see where the component position is. Inclination, clearly very important, and easily gleaned from the anteroposterior radiographs. And the position of the acetabular component in relation to teardrop is easily seen on these radiographs also. For example, this one led to limb length discrepancy because the acetabular component is inferiorly positioned. And only by going back and restoring that to the right anatomical site, you can address the preoperative limb length discrepancy. However, you also have to be aware that other subtle problems can exist, in particular the version of the acetabular component. So what do you do when you see a patient with instability? First, obtain their preoperative radiographs to see if the offset, position, etc. are all right. Scrutinize the component positioning. Again, be mindful that version problems on the acetabular component can easily be missed. And if necessary, obtain an additional radiograph or CT scan. If the component is malpositioned, you have to revise it. And revising an acetabular component is actually very easy. These are curved osteotomes that you can gently, but with patience, go behind the acetabular component, and you're able to remove it without any bone loss. Now, if you have a well-fixed cup, test the position, remove the screws, test its stability, and if it's stable, then this is how we sort of test the stability, you don't need to revise. If it's loose, you have to revise. No exceptions. If it's well fixed but malpositioned, you also have to revise. The only exception would be probably very elderly, frail patient in whom you might be able to cement a liner, for example. If it's well fixed, well positioned, but the patient still has instability, you have to look for a different cause. Usually it's soft tissue. So constrained liners used to be very useful adjunct for addressing instability, particularly in patients with abductor deficiency, or when there's unknown etiology, for example, neurological status, etc. Had great success rate in addressing instability of the hip. But if you're going to be putting a new cup in, if you've revised, you should be very cautious about the use of constrained liner, because that can transfer the forces to the interface of implant and bone. So you should really use constrained liner in the context of a very well-fixed cup that you can either use the locking mechanism that exists, or you can cement into that liner. If you're going to cement, you have to remove that ring, and then you have to create burr and basically create some form of cement interdigitation. You also need to burr the acetabular component to be able to get as much of that cement interdigitation. So constrained liners unfortunately increase wear, and they can cause catastrophic failures like you see over here. So what is new? Dual mobility, and we heard fantastic talks already. Dual mobility is fantastic option for instability. This question was discussed during the World Expert Meeting in Istanbul recently. Basically, the recommendation, and a very strong recommendation, is you should consider dual mobility in patients undergoing primary joint replacement who have a very high rate or high likelihood of instability, like alcohol abuse, neuromuscular pathology, abductor deficiency, cases of megaprosthesis. For example, this one, when there is no abductor mechanism, I think you should be using dual mobility right from the start. So instability of the hip is relatively common, and I think you need to evaluate components. Constrained liner is an option, but now dual mobility appears to have replaced it. But most importantly, prevention is the most important aspect. As they say, knowledge is knowing tomatoes a fruit, wisdom is not putting it in a fruit salad. Thank you very much.